Okay, guys, so this is the part one of the topic on pain, and then after discussing pain, we will go into the details of the orofacial pain. Pain is an unpleasant sensation caused by a noxious stimulus that is mediated only along a specific nerve pathway into the central nervous system where it is interpreted as pain. Orofacial pain refers to discomfort or pain experienced in the region of the mouth, jaws, face, and surrounding structures. This type of pain can originate from various sources, including dental conditions, temporomandibular joint disorders, sinus infections, muscle tension, nerve injuries, or even because of certain systemic conditions. Orofacial pain can manifest as a dull ache, sharp, stabbing sensation, could be burning, tingling, or even throbbing discomfort, depending upon the cause of the pain. It may be localized to a specific area or it can radiate to the adjacent regions as well, like in impacted third molar, where there would be inflammation of the operculum, pericoronitis, and patient would be having radiating pain. A proper diagnosis is essential to determine the etiology of orofacial pain and to develop an appropriate treatment plan. Pain encompasses various dimensions, including physical, cognitive, and emotional components. Three distinct types of pain can be identified based on their mechanisms, like nociceptive pain, inflammatory and neuropathic pain. Nociceptive pain serves as the fundamental defense mechanism, safeguarding us from the potential harm, like just if something is hot near you and you accidentally touch it, so you feel a pain and you withdraw your hand from that hot item. Just an example. Inflammatory and neuropathic pain conditions involve disruptive and frequently abnormal nervous system function due to persistent pathology or neuroplastic changes. Acute pain arises from activation of nociceptors for a limited time and is not associated with significant tissue damage. For example, a pinprick. Chronic pain is prolonged pain lasting for months or longer that arises from tissue injury, inflammation, nerve damage, tumor growth, could be because of certain lesions or occlusion of the blood vessels. Well, chronic or inflammatory pain can sensitize the nervous system, evoking chemical, functional, and even structural changes that serve to prime the pain processing pump. Chronic pain, such as lower back pain, the most common pain, rheumatoid and osteoarthritis, again, common types of reasons for the pain, and headache may result from constant inflammatory activity, which activates the G proteins. In some cases, the pain persists long after the injury heals. So that concept that pain is only persistent till the injury is there, that is not correct. Pain can persist longer even after the injury heals, but there is no treatment that will eliminate the pain. If we look at the pain terminology, pain, its definition is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Its clinical implications, certain patients, they are not able to communicate verbally, but we can look at their expressions, how they are feeling the pain if they are having some kind of pain. Allodynia, pain due to a stimulus that does not normally provoke pain, for example, touch, light pressure, or moderate cold or warmth. It is associated with neuropathy, inflammation, and certain headache states, a lower threshold where the stimulus and response mode differ from the normal state. Then the hyperalgesia, it is an increased response to a stimulus that is normally painful. And if we look at the clinical implication, it is associated with neuropathy or inflammation, reflects increased pain or suprathreshold stimulation. The stimulus and response mode are basically the same. Then the hyperesthesia, it is increased sensitivity to stimulation, excluding the special senses, includes both allodynia and hyperalgesia. And it is associated with neuropathy or inflammation. Hypoalgesia is defined as diminished pain in response to a normally painful stimulus. And if we look at the clinical implications, typical of neural damage, raised threshold, stimulus and response mode are the same, that is lowered response. Then analgesia, that is absence of pain in response to stimulation that would normally be painful, commonly observed after complete exotomy, means removal of the neuron or nerve block. It is not unpleasant. Hyperpathia, that is a painful syndrome characterized by an abnormally painful reaction to a stimulus, especially a repetitive stimulus, as well as an increased threshold may occur with allodynia, hyperesthesia, hyperalgesia, or dysesthesia. If we look at its clinical implication, typical of neuropathic pain syndromes, faulty identification and localization of the stimulus, delay, radiating sensation, and after sensation may be present, and the pain is often explosive in character. Then paresthesia. Paresthesia is an abnormal sensation, whether spontaneous or evoked, and it is typical of neuropathic pain syndromes. Hypoesthesia, decreased sensitivity to stimulation. Hypoesthesia is total or partial loss of sensation in a part of body. Sometimes it is accompanied by pins and needles tingling. In addition to losing a sense of pain, temperature, and touch, one may not feel the position of the numb part of their body. Dysesthesia, it is an unpleasant, abnormal sensation, whether spontaneous or evoked. Hyperalgesia and allodynia are form of dysesthesia as well. Pain classification based on origin: somatic pain, neurogenic pain, and psychogenic pain. Somatic pain refers to discomfort originating from the skin, muscles, ligaments, bones, or joints. This type of pain typically arises from damage or irritation to these structures and is often described as aching, throbbing, or a sharp type of pain. Somatic pain is typically well localized and may be exacerbated by movement or pressure on the affected area. It can result from various conditions, including injuries, fractures, sprains, strains, arthritis, or even surgical procedures. Management of somatic pain may involve a combination of physical therapy, medications, injections, and maybe some other interventions which are tailored to address the underlying cause and to alleviate the symptoms. Neurogenic pain refers to discomfort originating from dysfunction or damage to the nervous system. This type of pain arises from abnormalities in the peripheral or central nervous system, including nerves, spinal cord, or brain. Neurogenic pain can manifest as burning, tingling, shooting, or stabbing sensations, and it may be associated with conditions like neuropathy, nerve compression, nerve injury, or central sensitization disorders. If we look into the examples of neurogenic pain, they include diabetic neuropathy, sciatica, post-herpetic neuralgia, and complex regional pain syndromes. Treatment of neurogenic pain often involves a multidisciplinary approach, including medications, physical therapy, nerve blocks, neuromodulation techniques, and psychological interventions to manage the symptoms and to improve the quality of the life of the sufferer. Psychogenic pain. Psychogenic pain refers to discomfort that is primarily influenced by psychological factors such as emotions, thoughts, beliefs, or past experiences rather than solely originating from some physical damage or dysfunction in the body. This type of pain can be real and distressing, even though there may be no identifiable physical cause or injury. Psychogenic pain often manifests as chronic pain conditions, including somatic symptom disorder, conversion disorder, or other functional pain disorders. Psychological factors such as stress, anxiety, depression, trauma, or personality traits may contribute to the development or exacerbation of psychogenic pain. Treatment typically involves a multidisciplinary approach that addresses both the physical and psychological aspects of pain, including cognitive behavioral therapy, relaxation techniques, stress management, and medications to manage symptoms and improve the coping skills. Pain receptors. Pain is termed as nociceptive. Nocer means to injure or to hurt in Latin, and nociceptive means sensitive to the noxious stimuli. Noxious stimuli are stimuli that elicit tissue damage and activate nociceptors. Nociceptors are sensory receptors that detect signals from damaged tissue or the threat of damage, and indirectly also respond to chemicals released from the damaged tissue. Nociceptors are free nerve endings which are found in the skin, in the muscle, joints, bone, and viscera. Nerve endings contain transient receptor potential, TRP, transient receptor potential, channels that sense and detect the damage. These are known as pain receptors. They transduce a variety of noxious stimuli into receptor potentials, which in turn initiate action potential in the pain nerve fibers. This action potential is transmitted to the spinal cord and makes a synaptic connection in lamina 1 and lamina 2, or just lamina 2. So either in both of the laminae or in just one, either of the two. The cell bodies of nociceptors are mainly in the dorsal root and trigeminal ganglia. No nociceptors are found inside the central nervous system. Here we can see just an example. If there is some injury, so free nerve endings, which are the primary efferent terminals in the skin, they could be C fibers, they could be A delta fibers, and they carry the information to the spinal cord, to the dorsal horn, and from there, either through the lateral spinothalamic tract or through the spinothalamic tract, whatever, it will be going to the central nervous system, the information, and then the information from there will be carried down. Nociceptors. Nociceptors are not uniformly sensitive. They fall into several categories depending on their responses to mechanical, thermal, and or chemical stimulation liberated by the damage, tumor, and or inflammation. Factors which activate the nociceptors. Nociceptors respond when a stimulus causes tissue damage, such as that resulting from cut, strong mechanical pressure, extreme heat, etc., etc. The damage of tissue results in a release of a variety of substances from lysed cells, as well as from new substances synthesized at the site of the injury. Some of these substances activate the TRP channels, which in turn initiate action potentials. And these substances, they are globulin and protein kinase, arachidonic acid, histamine, nerve growth factor, substance P, and calcitonin gene-related peptide. At times, a question is being asked that when we feel pain due to some pulpal inflammation, so it is due to what? It is due to the substance P and calcitonin gene-related peptide. Remember that. Then potassium K, or potassium, or the K is the sign for potassium. Then serotonin, acetylcholine, low pH solution. Low pH means it will be acidic, and ATP. Then muscle spasm and lactic acid. Responses to acute pain: increased heart rate, increased respiratory rate, elevated blood pressure, pallor or flushing, and dilated pupils. There will be diaphoresis. Diaphoresis means excessive sweating or perspiration. There will be increased blood sugar, decreased gastric acid secretion, decreased gastric motility, and decreased blood flow to the viscera, kidney, and skin. Nausea occasionally occurs in case of pain, acute pain. Psychological and behavioral responses to the acute pain. Patient will be having a sense of fear, general sense of unpleasantness or unease, and anxiety. Chronic pain. Chronic pain is persistent or intermittent, usually defined as lasting at least 6 months. The cause is often unknown, often develops insidiously, very often is associated with a sense of hopelessness and helplessness. And in certain cases, due to chronic pain, because they are obscure pain, they are not very well defined pain, and patient even goes into the depression. Pain threshold and pain tolerance. Pain threshold is the point at which a stimulus is perceived as pain. It does not vary significantly among healthy people or in the same person over time. Perceptual dominance, a term which we use, it is the intense pain at one location of the body, and it may cause an increase in the pain threshold in another location. Person forgets about the other pain because of some new pain. We are discussing about the pain threshold and pain tolerance. The pain tolerance is expressed as duration of time or the intensity of pain that an individual will endure before initiation over pain responses. It is influenced by a person's cultural prescriptions, their expectations, role behaviors, and physical and mental health. Pain tolerance is generally decreased with repeated exposure to pain by fatigue, anger, boredom, apprehension, and even by sleep deprivation. Tolerance to pain may be increased by alcohol consumption, medication, hypnosis, warmth, distracting activities, strong beliefs, or faith. Pain tolerance varies greatly among people and in the same person over time. A decrease in pain tolerance is also evident in children, teenagers, and elderly. At times, a question is asked that patient was feeling a lot of pain when they were at home due to some pulpitis, but when they reached the dentist office, what happened? Why they are not feeling pain? Because of their parasympathetic nerve supply and like the sympathetic nerve supply, there is some less blood flow towards that area, and that is why they are not having pain. So that could be one reason, which we will discuss in detail when we are going to discuss about the orofacial pain in detail in the next lecture. Neuroanatomy of pain. The portions of the nervous system responsible for the sensation and perception of pain may be divided into 3 areas: the afferent pathways, then the central nervous system, and then the efferent pathways. The efferent portion is composed of nociceptors. Then these are the nerve endings of the nociceptive nerve cells, which we have already discussed, efferent nerve fibers, and spinal cord network. Efferent pathways terminate in the dorsal horn of the spinal cord, that is the first efferent neuron. Second efferent neuron creates a spinal part of the efferent system. This is the synapse over here. The portion of the CNS involved in the interpretation of the pain signals are the limbic system, reticular formation, thalamus, hypothalamus, and cortex. The efferent pathway is composed of the fibers connecting the reticular formation, midbrain, and substantia gelatinosa are involved in different behavioral and psychological responses to pain, and they are responsible for modulating pain sensation. pain perception. The brain is the first one which perceives the sensation of pain, the thalamus sensitive cortex, perceiving, describing, and localizing the pain. Parts of thalamus, brainstem, and reticular formation identify dull, longer lasting, and diffused pain. The reticular formation and limbic system control the emotional and affective response to pain. Cortex, thalamus, and brainstem are interconnected with the hypothalamus and autonomic nervous system. Perception of pain is associated with an autonomic response. The role of afferent and afferent pathways in processing of pain information. Nociceptive pain, nociceptors, these are the endings of small unmyelinated and lightly myelinated afferent neurons. Their stimulators, they are chemical, mechanical, and thermal noxiae. Mild stimulation will lead to positive, pleasurable sensation, for example, tickling or just caressing. A strong stimulation will cause pain. Location in muscles, tendons, epidermis, subcutaneous tissue, then joints, visceral organs, etc., etc. They are not evenly distributed. They are more common or more abundant in skin than in the internal structures. We use the term transduction. Transduction is the process by which afferent nerve endings participate in translating the nauseous stimuli, for example, a pinprick, into the nociceptive impulses. Afferent pathways. From nociceptors transmitted by small A delta fibers and C fibers to the spinal cord. Usually question comes that which of the nerve fibers they are responsible for carrying the sensation of pain, A delta fibers and C fibers. They form synapses with neurons in the dorsal horn. From dorsal horn transmitted to higher part of the spinal cord and to the rest of the CNS by spinothalamic tracts. The small unmyelinated C neurons are responsible for the transmission of diffused burning or aching sensations. Transmission through the larger myelinated A delta fibers occurs much more quickly. Question also comes on that. Which of the fibers they carry the sensation more quickly? A delta. And why? They are larger and myelinated. A delta fibers carry well-localized sharp pain sensations. Afferent analgesic system. Its role is inhibition of afferent pain signal and mechanisms. Pain afferent on their way up to the CNS send branches to the periaqueductal gray or PAG, that is gray matter surrounding the cerebral aqueduct in the midbrain, and stimulates the neurons there. So there will be activation of afferent descendant anti-nociceptive pathways. From there, the impulses are transmitted through the spinal cord to the dorsal horn. There they inhibit or block the transmission of nociceptive signals at the level of dorsal horn. This is the descending anti-nociceptive systems schematic diagram. Here we can see this is amygdala, the learned danger signals and the innate danger signals. They are all getting over here, causing the situation of fear when there will be any information or any nauseous stimulus is coming and carrying the information through the RVM, through the PAG or amygdala, pituitary adrenal axis. It is also releasing steroids at that time, which will be helping in coping with the situation, with the anxiety and the painful situation. Well, role of spinal cord in pain processing. Most of afferent pain fibers terminate in the dorsal horn of the spinal cord. Some of them, however, extend caudally or rostrally. Caudally means towards the feet and rostrally towards the cranium for several segments before they terminate. The A beta fibers, some large A delta fibers and small C fibers terminate in the laminae of dorsal horn and in the substantia gelatinosa. Before I forget, remember A beta fibers, they become hyper responsive, or they carry a lot of sensation, they become hypersensitive in case of allodynia. Remember that. Usually question also comes from that. So before I forget, I'm just letting you know. Usually these fibers, they are not too sensitive. They are just for the light touch. But in case of allodynia, they become hypersensitive, A beta fibers. The laminae then transmit specific information about injury or about gentle pressure to the second afferent neuron. Second afferent neurons, they transmit the impulse from the substantia gelatinosa and laminae through the ventral and lateral horn, crossing in the same or adjacent spinal segment to the other side of the cord. From there, the impulse is carried through the spinothalamic tract to the brain. The two divisions of the spinothalamic tract are neospinothalamic tract and the paleospinothalamic tract. The two divisions of the spinothalamic tract, the neospinothalamic tract, it carries information to the midbrain, thalamus, and postcentral gyrus, where the pain is perceived. And the paleospinothalamic tract, it carries information to the reticular formation, pons, limbic system, and midbrain. More synapses to different structures of the brain are being made over there. So this is the neospinothalamic tract, and this is the paleospinothalamic tract. Theory of pain production and modulation. Most rational explanation of pain production and modulation is based on gate control theory, which was presented by these two scientists. According to this theory, nociceptive impulses are transmitted to the spinal cord through large A delta and small C fibers. Another question they can ask you about the size of the fibers. So A delta, they are large, and C fibers are small. These fibers create synapses with neurons in the substantia gelatinosa. The cells in this structure function are a gate regulating transmission of impulses to the central nervous system. Stimulation of larger nerve fibers, A alpha, A beta, causes the cells in substantia gelatinosa to close the gate for transport of painful information centrally. A closed gate leads to decreased stimulation of T cells, the second afferent neuron, which decreases the transmission of impulses and diminishes the pain perception. Stimulation of small fibers input inhibits cells in the substantia gelatinosa and open the gate. An open gate increases the stimulation of T cells, which will cause transmission of impulses and will enhances the pain perception. In addition to gate control through large and small fiber stimulation, the central nervous system through afferent pathways may partially close, or open the gate too. It can open the gate too as well. Cognitive functioning may thus modulate the pain perception. Action of the endorphins. Endorphins, they act by attaching to opiate receptors on the plasma membrane of the afferent neurons. Endorphins are present in our body. The result of them is inhibition of, it is the result of them, or the result then is inhibition of releasing of the neurotransmitter, thus blocking the transmission of the painful stimulus. Allodynia. Allodynia is usually question comes that write a note on allodynia. So here you can always modify it and you can write it. Allodynia is pain resulting from a stimulus that does not normally produce pain. For example, light touch to sunburned skin produces pain because nociceptors in the skin have been sensitized as a result of reducing the threshold of the silent nociceptors. Another explanation of allodynia is that when peripheral neurons are damaged, structural changes occur and the damaged neurons reroute and make connection also to sensory receptors. That is, touch-sensitive fibers reroute and make synaptic connections into the areas of the spinal cord that receive input from the nociceptor. That's why they become hypersensitive. So over here, we are done with our today's part of this lecture, and next week we are going to discuss different types of pains which we feel and in our head and neck region and how we have to deal with them.